Assalamu alaikum everyone and good evening. Today the topic of our lecture is embryology for dentists and Dr. Naghman Zuberi is going to be giving a lecture about it. Sir, you can take from here.
Good morning, everyone. And as I received the message from the organizers of this channel that many people are asking about some overview of embryology from the dentistry point of view. So here we are with the lecture on embryology, just an overview. We are not going into the detail. There are almost 94 slides on this topic, and we will go slow so that you can understand. It is better if you can note down your queries and your questions because while I am having this screen on, I am not able to see your questions. And then later, you can always send the questions or wherever this is posted, you can post your question, your queries, and tag me in the comment box. So it will be easier for me to see your questions at that time, and I would be able to answer those completely. So let's start with the lecture. Prenatal development. Actually, we divide it into two parts, the embryonic development and then the fetal development. So, in the embryonic development, firstly, the fertilization occurs, and then there is the cleavage formation, blastocytes are forming, then implantation, and then the bilaminar embryonic disc it appears. Well, after this 2 weeks, the first 2 weeks, then it will be morphogenesis and differentiation phase. Here, different organs they start developing, and that is known as the fetal phase or the start of the fetal phase. The fetal phase actually starts from the 21st day onward. Well, in the beginning, when there is differentiation, the differentiation of the morula into the blastocyst. Here, the trophoblasts they start appearing. Trophoblasts, they are those cells that form the outer layer of a blastocyst, and they are present 4 days post fertilization in human being. They provide nutrients to the embryo, and then they develop into a large part of the placenta. In the second week of gestation, then we have the bilaminar germ disc. Bilaminar, it has two layers, the ectoderm and the endoderm. The endoderm, it is forming at the preprochondral plate. In the third week, then it will be becoming the triploblastic embryo, means the third layer also starts appearing. We had ectoderm, we had endoderm, now the mesoderm also starts appearing at this stage. And it is known as the trilaminar embryonic disc. Ectoderm, endoderm, and the mesoderm. First 3 weeks, they lead to formation of triploblastic embryo. That's it. And next 3 to 4 weeks, that will be dedicated to the differentiation of major tissues and organs, including head and face and tissues responsible for tooth development, differentiation of the nervous tissue from ectoderm, differentiation of the neural crest cells, differentiation of the mesoderm, and folding of the embryo. So there will be two planes, the rostrocaudal and the lateral. I will show you the pictures how the folding it starts appearing. Now, here the neural crest, it starts appearing. The neural tube undergoes massive expansion to form the forebrain, midbrain, and the hindbrain. This is the neural groove. Components of the mesoderm. Along the trunk, paraxial mesoderm breaks up into segmented blocks, which we call somites. Each somite has a sclerotome, two adjacent vertebrae, and a disc. Myotome, which is responsible for the muscle, a dermatome, connective tissue of the skin over the somite. So basically, it is contributing to these three things: the muscles, the skin, and the bones and the vertebrae and discs. In the head region, the paraxial membrane, the paraxial mesoderm only partially fragments to form a series of numbered somatomeres, which contribute to the formation of head and neck musculature. Intermediate mesoderm, that is going to give the urogenital system. Lateral plate mesoderm, connective tissue of muscle and viscera, serous membrane of the pleura, pericardium and peritoneum, blood and lymphatic cells, cardiovascular and lymphatic system, spleen, and the adrenal cortex. In the head, the neural tube undergoes massive expansion to form the forebrain, midbrain, and the hindbrain, three parts of the brain. The hindbrain segments into series of 8 bulges, which are known as rhombomeres. And these rhombomeres, they play actually an important role in the development of head, the skull. This is how the folding occurs: the head folding, the tail folding, and the lateral folding. Two lateral, bilateral. Head fold forms a primitive stomodium, which is your future oral cavity, leading to ectoderm lining the stomodium, and the stomodium separated from the gut by buccopharyngeal membrane. Well, the folding, it is starting at the 24th day and continue till the end of 4th week. These figures, they are taken from Tenkate. All of us are familiar with the Tenkate. So over here, it is antero-posteriorly. The neural crest is here. This is the future oral cavity. And finally, this is the cardiac bulge and the future oral cavity. Neural crest cells. Group of cells separate from the neuroectoderm, migrate and differentiate extensively, leading to formation of cranial sensory ganglia and most of the connective tissue of the head. Embryonic connective tissue elsewhere is derived from mesoderm, and that is known as mesenchyme. But in the head, it is known as ectomesenchyme because of its origin from the neuroectoderm. That's why ectomesenchyme term is being used. When we look at the ectoderm, mesoderm, and endoderm, and which tissues are coming from all these three layers: ectoderm, epidermis of the skin and its derivatives, including sweat glands and hair follicles; epithelial lining of the mouth and anus; cornea and lens of eye, nervous system, sensory receptors in epidermis, adrenal medulla, tooth enamel. Tooth enamel comes from ectoderm. Epithelium of pineal and pituitary glands. Mesoderm, notochord, skeletal system, muscular layer of stomach and intestine, excretory system, circulatory and lymphatic systems, reproductive system, except the germ cells. Dermis of the skin, lining of the body cavity and adrenal cortex. Then comes the endoderm. It gives epithelial lining of the digestive tract, epithelial lining of the respiratory system, lining of urethra, urinary bladder and reproductive system, liver, pancreas, thymus, thyroid and parathyroid glands. So endoderm, the internal layer, it is giving the lung cells, the alveolar cell, thyroid cells, and the digestive cells, the pancreatic cells, etc., etc. Mesoderm, it is providing us cardiac muscle cells, skeletal muscle cells, tubule cells of the kidney, red blood cells, and the smooth muscle cells in our GIT. Ectoderm, the external layer, it is providing us the skin cells of epidermis, neurons for the brain, and the pigments, the coloring pigments for our skin. The major derivatives of the embryonic germ layers. From epiblast, we have like three layers, the ectoderm, mesoderm, and the endoderm. From the mesoderm, the intermediate mesoderm, kidneys and gonads, and from somites, the sclerotome, vertebrae and ribs, dermatome, dermis of the dorsal body region, and myotome, trunk and limb musculature. From the notochord, nucleus, pulposus of the invertebral discs, and the lateral plate and mesoderm, we get somatic mesoderm, the parietal cirrus, and the dermis of the ventral body region, connective tissue of the limbs, bones, joints, and ligaments. Then the splenic mesoderm. Here we get all our visceral organs, like the digestive system and the visceral serosa, then heart and the blood vessels, etc., etc. Endoderm, it provides epithelial lining and glands of the digestive and respiratory tracts. Ectoderm, we have already discussed about it, that epidermis, hair, nails, glands of the skin, brain and spinal cord. Neural crest provides us sensory nerve cells and some nerve structures, pigment cells, portions of the skeleton, blood vessels in head and neck. Well, neural crest cells, their derivatives, nervous tissue, connective tissue, pigment cells, sensory ganglia, endocrine tissue, autonomic nervous system, and the muscles. Most of the time, we get confused about the neural crest cell derivatives, and we consider that probably ameloblasts, they are derived from the neural crest cells. No, that is not the correct thing. Teeth develop from two types of cell in the beginning: stomodial ectoderm, which forms ameloblasts, and cranial neural crest derived ectomesenchymal cells, which form odontoblasts. So odontoblasts are coming from the neural crest cells, and ameloblasts are coming from the ectoderm of the stomodium. Now over here, head formation starts. It is like one of the first are occipital somites, they start forming. Midbrain, forebrain, and the hindbrain. Hindbrain actually makes most of the brain. This is the mesenchymal area. Now the neural crest cells, they start migrating. The midbrain, hindbrain, and the forebrain. Here you can see migration of the cranial neural crest cells. This is the anterior midbrain, posterior midbrain, and the anterior hindbrain, the reddish in the color. At this time, problems may occur and certain syndromes, they may appear. Like the Treacher-Collins syndrome, that is characterized by the defects of structures that are derived from the first and second branchial arches and is due to failure of neural crest cells to migrate properly to the facial region. Well, now the buccopharyngeal membrane ruptures between 24th and the 26th day. This is the cardiac bulge. This is the frontal prominence, and this is the future GIT or gut. This is the future oral cavity, the stomodium. Here, again, one schematic diagram, and this is almost 3.5 weeks old fetus. This is the true picture. You can see the stomodium. This is the frontal prominence, and then the maxillary prominence, the mandibular prominences. Both of these are coming from the first branchial arch. This is almost 26-day-old embryo. Branchial arches form in the pharyngeal wall, which has lateral plate mesoderm sandwiched between the ectoderm and endoderm. As a result of lateral plate mesoderm proliferation and subsequent migration by neural crest cells, it occurs. Almost 3 to 3.5 week old embryo. Sagittal view of the branchial arches with corresponding grooves between the each arch. Pharyngeal pouches are seen in the wall of the pharynx. The aortic arch vasculature leads from the heart dorsally through the arches to the face. Now, what happens to the pharyngeal grooves and pouches? First, groove and pouch. External auditory meatus is derived from it, the tympanic membrane, tympanic antrum, mastoid antrum, then pharyngotympanic or eustachian tube. Second, third, and fourth grooves, they are obliterated by the overgrowth of the second arch, forming a cervical sinus. If it persists, forms the branchial fistula that opens into the side of the neck, extending from the tonsillar sinus, which is a congenital malformation. Second pouch is obliterated by the development of palatine tonsil. Third pouch dorsally forms inferior parathyroid gland. Ventrally forms the thymus gland by fusing with the counterpart from opposite side. Fourth pouch, the dorsal, it gives rise to the superior parathyroid gland. Ventral, now here there is a trick. Third pouch, it gives the inferior parathyroid glands. And the fourth pouch, it gives the superior parathyroid gland. Ventral gives rise to the ultimobranchial body, which gives rise to the parafollicular cells of the thyroid gland. Fifth pouch in humans is incorporated with the fourth pouch. They become fused. So fifth is not present. Either it is not present or it fuses at a very early age. Like very early age means the prenatal age, right after the, like within a couple of weeks. Tissue from arch 2 and 5, they grow towards each other to make the branchial arches, and grooves, they disappear. The grooves, they disappear. Now, proliferation is an overgrowth. It continues. Now, over here in this picture, I will just enlarge it. And we can see that thyroid gland, it starts descending from the tongue. And the foramen cecum it's going to be there on the tongue, which will be at the sulcus terminalis. Like if I will be able to get the pen. Yes. So what is going to happen? The tongue, it has this sulcus terminalis, which is separating the anterior part and the posterior part, and thyroid is developing in this area. It descends down, and if it persists, then it will become the lingual thyroid. It will be called lingual thyroid. It descends and starts growing in size. Otherwise, like in some of the cases, very minority of the cases, it stays here at the foramen cecum. When it descends, it leaves behind the foramen cecum, which is at the bilateral, this sulcus terminalis. Well, let me get my pointer back. Yeah. Over here, you can see the inferior parathyroid glands and the superior parathyroid glands and the ultimobranchial body, which will give the follicular cells of the thyroid. We are discussing about the anatomy of the brachial arches. The cartilage of the first arch is Meckel's cartilage, and second arch is Ricketts cartilage. Other arches, their cartilages are not named. Some mesenchyme around the cartilage gives rise to striated muscle. Each arch also has an artery and a nerve. Nerve, it is two components, motor and sensory. Sensory nerve divides into two branches. The posttraumatic branch covers the anterior half of the arch epithelium, and the pretraumatic, it is going to cover the posterior half of the arch epithelium. Here, the color, it tells us which is coming from the ectoderm, which part is coming from the endoderm, and which part is coming from the mesoderm. Meckel's cartilage has a close relationship with the developing mandible, but previously it was thought that it ossifies into mandible. That is not true. It does not contribute to it. Only mandible is forming around it. It just provides the blueprint for the development of, or for the, uh, you can say, uh, the formation of mandible around it. Indicates the position of the future mandible. The mandible develops by intramembranous ossification. Though, like some of the authors, they say that mandible having a condyle on this side and a condyle on this side, like two condyles, and then there is a long neck, and then there is like a body on both sides, which then joins. So some of the authors, they say that it looks like that it was basically a long bone which is bent, but the development is not endochondral, just like the development of long bones. It is like other uh, bones of the skull. It is intramembranous. The ossification is intramembranous. We have to keep this thing in our mind. Innervation is coming from the trigeminal nerve. Then comes the Ricketts cartilage. Dorsal end, it gives stapes and styloid process. Ventral end, lesser horns of hyoid bone, and superior part of the body of the hyoid bone. Its innervation is from the facial nerve. Cartilage of the third arch, inferior part of the body, and greater horns of the hyoid bone, and cartilage of the fourth and sixth arches fuse to form the laryngeal cartilage. Here again, just for the revision, this table, first mandibular arch, the nerve is cranial nerve 5 or trigeminal nerve. Muscles, it gives muscles of mastication, mylohyoid, and anterior belly of digastric, only anterior belly of digastric. Tensor tympani and tensor veli palatini. All these muscles, they are supplied by trigeminal nerve, various branches of trigeminal nerve. Skeletal structure, which are being derived from the first, malleus and incus. Ligaments, anterior ligament of the malleus is phenomandibular ligament. Second, which is known as hyoid, the cranial nerve 7 or facial nerve. Muscles of facial expression, they are originating from here. Which muscles? Buccinator, auricularis, frontalis, platysma, orbicularis oris, and orbicularis oculi. Then stapedius, stylohyoid, posterior belly of digastric. So anterior belly of digastric is coming from the deferent arch, and the posterior belly is coming from the deferent arch. So their nerve supply is also different. Skeletal structures, which are being derived from the second arch, stapes, styloid process, lesser cornu of hyoid, upper part of the body of the hyoid bone, ligaments, stylohyoid ligament. Third arch, glossopharyngeal, and stylopharyngeus muscle, that is being derived from it. Skeletal structures, greater cornu of hyoid, lower part of the body of hyoid bone. Fourth and sixth arches, the nerves, superior laryngeal branch of the vagus nerve and recurrent laryngeal branch of the vagus nerve. The muscles, cricothyroid, levator veli palatini, constrictors of the pharynx, intrinsic muscles of the larynx, striated muscles of the esophagus. And skeletal structure, thyroid cartilage, cricoid cartilage, arytenoid cartilage, corniculate cartilage, and cuneiform cartilage. This table shows the embryonic development in the time and the related syndromes that may arise during those periods. Day 17, that is very important, and chances of fetal alcohol syndrome may it may develop during this, like at this time. Mothers who are having very high alcohol level, and nowadays actually it is a general consideration that pregnant ladies should not take alcohol at all. So those ladies, their children, they have a chance that they may develop the fetal alcohol syndrome. Days 18 to 23, anencephaly. Days 19 to 28, hemifacial microsomia, mandibulofacial dysostosis, which is known as Treacher-Collins syndrome, and certain limb abnormalities. Days 28 to 38, cleft lip and or cleft palate, other facial clefts, they may appear because this is the time when the lip and palate, they are being formed. Days 40 to 45, again the cleft palate. Now the chances of cleft lip, they are gone. Cleft palate may still appear. Day 50th to birth, achondroplasia, synostosis syndrome, or Cruzen's-Appert syndrome, etc., etc. After cleft lip and cleft palate is over, then there will be chances for these problems. Fetal alcohol syndrome, as I have, sorry for the spelling, the E is missing, I don't know why. So fetal alcohol syndrome, this is the correct spelling. What would be the clinical features? Low nasal bridge, then apicanthal folds, and minor ear abnormalities may be there, micrognathia, and upper lip will be very short and flat, and philtrum will be missing. Philtrum will be missing. These are the clinical features of fetal alcohol syndrome. In Treacher-Collins syndrome, which is also known as mandibulofacial dysostosis, well, there will be generalized lack of mesenchymal tissue in the lateral part of the face is the major cause of the characteristic facial features. Here you can see there will be the intercanthal distance will be very high, the nasal bridge will be too broad, and facial features, they will be giving you a typical Treacher-Collins syndrome type appearance. There would be a chance that they may have very short mandible. They also have hearing problems. Hemifacial microsomia. It could be just appearing on one side. In hemifacial microsomia, both the external and the mandibular rami are deficient or absent on the affected side. Cruzon syndrome. This is a typical facial feature of the Cruzon syndrome. It could be moderate, it could be severe as well. Aortic vasculature development. At 4 weeks, the anterior vessels have passed through each branchial arch tissue and have disappeared. The pouches project laterally between each arch. At 5 weeks, and the third branchial arch vessel becomes the common carotid artery, which supplies the face by means of the internal carotid and the stapedial arteries. Face, neck, and brain are supplied by the common carotid through internal carotid. But by 7 weeks, the circulation of the face and neck shifts from the internal carotid to the external carotid. Before that, it was just internal carotid. The internal carotid continues to supply to the brain. Now, what is going to happen? The aortic arch changes, they start occurring. Aortic arch vessels like number 1, number 2, and number 5. Number 1, number 2, and the 5, they disappear. Arch number 3, it becomes the common carotid artery. Arch 4 becomes the dorsal aorta and enlarges so that the common carotid arises from the aorta. And arch number 6 becomes the right and left pulmonary arteries. Face and brain are supplied first by the internal carotid artery. We have already discussed it. Facial vessels detach from the internal carotid and attach to the external carotid artery. Muscle cells in the first arch become apparent during the 5th week and begin to spread within the mandibular arch into each muscle site's origin in the 6th and 7th week. These form the muscles of mastication, masseter, medial pterygoid, lateral pterygoid, temporalis muscles. They all relate to the developing mandible. By Week 7, the muscles of second arch grow upward to form the muscles of the face. As these muscles, they grow and expand, they form sheet over the face and form the muscles of facial expression. Facial muscles, they grow from the second brachial arch to cover the face, scalp, and posterior to the ear. And masticatory muscles, they are coming from the first arch, the mandibular arch. Now the cranial nerves, they start growing into the branchial arch. The first arch, it is innervated by the trigeminal nerve. The second arch is innervated by the facial nerve, and then the glossopharyngeal nerve. Cartilage is derived from the branchial arches. We have already discussed arch 1, Meckel's cartilage and incus, arch 2, stapes, stylohyoid and lesser hyoid, arch 3, greater hyoid, arch 4 and 6, thyroid, and the laryngeal cartilages. Now, what is going to happen at this stage? The congenital auricular sinuses and cysts, they may appear. It is very inconspicuous type of sinus which would be present, and that is basically a congenital anomaly. Branchial cysts, branchial sinuses, branchial fistula, branchial vestiges, which are cartilaginous or bony remnants, and branchial cysts, they may appear at this stage. So, firstly, the fusion, it will start, and keep in mind the lower jaw it forms before the upper jaw. The proliferation of these prominences, it will be occurring, and it shows that now they are going to fuse, and the two nasal prominences, they appear around the placards. The lateral nasal prominence and the medial nasal prominence, they will join to give the philtrum and the anterior lip, etc., etc. And finally, the fusion is going to occur, and we are going to have firstly our the anterior premaxilla, and later the secondary palate formation is going to occur. The tongue is going to regress. We have already discussed it in our previous lecture. So just for the revision, we are not going into the detail. You can always, if you have any issues about it, you can always go back to our posterior, like the previous lecture, and over there you will find all the details about the development of human face. So towards the 14th week, the whole of the face is complete. The middle portion of the upper lip, it is formed by the fusion of the medial nasal process of both sides along with the frontonasal process. The lateral portion of the upper lip, fusion of the maxillary process of each side with the medial nasal process, not with the lateral nasal process. Keep this thing in your mind. Lower lip is formed by the fusion of the two mandibular processes, and keep in mind the lower lip, it forms before the upper lip. Unusual fusion between maxillary process and lateral nasal process, leading to canalization and formation of the nasolacrimal duct. Nasolacrimal duct from the nasolacrimal groove. Well, clefting may occur, cleft lip and cleft palate. Now we are going to discuss about the pituitary gland development. It is ectodermal in origin and develops from the two sources. An upgrowth from the ectodermal roof of the stomodium called hypophysial diverticulum, the Rathke's pouch. It is adenohypophysis. This portion is known as adenohypophysis. A downward growth from the neuroectodermal derm of the diencephalon called the neurohypophysial diverticulum, and this is the neurohypophysis. During the 4th week of development, a hypophysial diverticulum, the Rathke's pouch, projects from the roof of the stomodium and lies adjacent to the floor, the ventral wall of the diencephalon. By the 5th week, this pouch has elongated and has become constricted at its attachment to the oral epithelium and is in contact with the infundibulum derived from the neurohypophysis. So This is the cerebral vesicle. This is the diencephalon. This is the hypophyseal diverticulum over here. The two sources. And finally, the hypophysis. Both of them, one is coming from one source, the other one is coming from the other source, and then they form the pituitary gland. Derivation and terminology of the pituitary gland. The oroectoderm, adenohypophysis, hypophyseal diverticulum, and from the roof of the stomodium. It is the glandular portion, pars tuberalis and the pars intermedia. Then the neuroectoderm, it is neurohypophyse or pars nervosa. Neurohypophyseal diverticulum from the floor of the diencephalon. This is the nervous portion, and infundibular stem and the median eminences, they are coming from here. Clinical significance of the development of pituitary gland. Craniopharyngiomas develop from the remnants of the stalk of hypophyseal diverticulum in pharynx of sphenoid bone. Now, formation of the palate, the crucial time is between week 7 and 9. But basically, anywhere like from the 6th week to 9th week, the problem may occur. Palate develops from the primary palate and the secondary palate. The primary palate develops at about 28 days of gestation. Primary palate develops from the frontonasal and the medial nasal processes and eventually forms the premaxillary portion of the maxilla. The secondary palate develops between the 7th and 8th week of gestation and completes in the 3rd month. The critical period of palate development is from the end of the 6th week, as I told you, till the beginning of the 9th week. So if the tongue is not regressing or maybe the fusion is not occurring, then there will be chances of having the clefting. It could be just isolated cleft of the palate without cleft of lip or cleft of the premaxilla. Formation of the tongue. The tongue begins to develop at about 4th week. The oral part, the anterior 2/3, develops from the 2 distal tongue buds, lateral lingual swelling, and a median tongue bud, the tuberculum impar. These are coming from the first branchial arch. That is why the innervation is from the trigeminal nerve, the lingual branch of the trigeminal nerve. We are talking at the moment about the sensation. The pharyngeal part develops from the copula and the hypobranchial eminence, 2nd, 3rd, and 4th branchial arches. The innervation is 9th cranial nerve, that is glossopharyngeal nerve. The line of fusion of the oral and pharyngeal parts of the tongue is roughly indicated in the adult by a V-shaped line, which we call the terminal sulcus or sulcus terminalis. At the apex of the sulcus terminalis is the foramen cecum. I have already told you about that. Muscles of the tongue, they develop from the occipital somites and they are innervated by the hypoglossal nerve. Now over here we can see this is the distal tongue bud and this is the median tongue bud, and here we can see the tuberculum impar, the copula, the hypopharyngeal eminence, etc., etc. The tongue is completed. This is the oral part of the tongue. This is the pharyngeal part of the tongue. This is the foramen cecum and sulcus terminalis, and here is the epiglottis, etc., etc. Well, the pharyngeal arch one, the embryonic precursor, intermediate structure is the median tongue bud, adult structure overgrowth by the lateral lingual swelling, and innervation lingual branch, sensory of mandibular division of the trigeminal nerve. As well as not the median tongue bud, but the lateral lingual swellings as well. Mucosa of the anterior 2/3 of the tongue is coming from that. Chorda tympani from the facial nerve. Innervating arch 2 innervates all taste buds except the velate papillae. Pharyngeal arch 2, copula, and overgrowth by other structures. These are the adult structure. Pharyngeal arch 3, large ventral part of the hypopharyngeal eminence, mucosa of the most of the posterior one-third of the tongue is coming from it. Sensory branch of glossopharyngeal nerve, the also supplies the velate papillae. Pharyngeal arch 4, a small dorsal part of the hypopharyngeal eminence, mucosa of the small dorsal region of the tongue, sensory fibers of the superior laryngeal branch of vagus nerve, they are coming from there. Occipital somites, myoblasts, they give the intrinsic muscles of the tongue, and those are innervated by the hypoglossal nerve, as well as the palatoglossus muscle, the superior laryngeal branch of vagus nerve, it innervates the palatoglossus. This is an exception because it is coming from the palatal side. So origin is palate, and it is inserting into the tongue. Palatoglossus muscle, its nerve supply is different. The lingual papillae, they appear by the end of 8th week. Velate and foliate papillae appear first, then the fungiform and filiform, these papillae, they appear between 10 to 11 weeks. Taste buds develop during the 11th to 13th weeks by inductive interaction between epithelial cells of the tongue and invading the gustatory nerve cells from chorda tympani, glossopharyngeal, as well as from the vagus nerves. This is just an adult and how the thyroid it descends. This is a lingual thyroid, and at times the thyroglossal duct, that is the cyst, it may develop if the duct is patent. Well, here we can see just the pharyngeal arches and their derivatives. Development of the cranial base and jaws. The bones of the cranial base are formed initially in cartilage and are transformed by the endochondral ossification of bone. The picture over here, it shows the chondrocranium at 8 weeks of intrauterine development. A continuous plate of cartilage extends from the nasal capsule posteriorly all the way to the foramen magnum at the base of the skull. This one. First arch, second arch. Cartilage is a nearly avascular tissue whose internal cells are supplied by diffusion through the outer layers. This means, of course, that the cartilage must be very thin. At early stages in development, the extremely small size of the embryo makes a chondroskeleton feasible. But with the further growth, it is not longer possible without an internal blood supply. Otherwise, blood supply will be very, very minimal. During the 4th month in utero, there is an ingrowth of the blood vascular element into the various points of the chondrocranium and the other parts of the early cartilaginous skeleton. These areas become centers of ossification. Now the bone is going to form and cartilage is going to be replaced, at which cartilage is transformed into bone and islands of bone appear in the sea of surrounding cartilage, like this. The cartilage continues to grow rapidly but is replaced by bone with equal rapidity. Eventually, the old chondrocranium is represented only by small areas of cartilage interposed between the large sections of the bone. Not all the bones of the adult skeleton were represented in the embryonic cartilaginous model, and it is possible for bone to form by secretion of bone matrix directly within the connective tissues. Bone formation of this type is known as intramembranous bone formation. This type of ossification occurs in the cranial vault and maxilla as well as mandible, both the jaws. Development of the cranial base and jaws. The mandible of higher animals, they develop in the same area as the cartilage of the first pharyngeal arch, which is Meckel's cartilage. It would seem that the mandible should be a bony replacement for this cartilage. In fact, it is not. It is basically forming around it. Meckel's cartilage largely disappears as the bony mandible develops. Rests of this cartilage are transformed into portion of the two small bones of the middle ear as well as sphenomandibular ligament could be its remnant. It is not, some of the authors, they say that it is the remnant. So, mandible forms around the Meckel's cartilage, and the nerve is mandibular branch of the trigeminal nerve because mandible is coming from the first arch. Here we can see the Meckel's cartilage, then the membranous bone developing around the Meckel's cartilage. This is the tongue, and the tooth germ, it starts appearing. What happens to the Meckel's cartilage? The posteriorly malleus of the inner ear, they are formed from the Meckel's cartilage, sphenomandibular ligament. Anteriorly may contribute to mandible by endochondral ossification. Not always proven. Some of the authors, they still believe in that. And rest is resolved completely. Secondary cartilages. 3 secondary cartilages govern further growth of the mandible until birth. Condylar cartilage, it is the most important one. Coronoid cartilage and the symphysial cartilage between the symphysis, the two-side mandible, symphysis area. So the condylar cartilage, coronoid cartilage, and the Meckel's cartilage over here appears during 12th week and occupies most of the ramus and is quickly ossified by the endochondral ossification. This is the area of the condylar cartilage where endochondral ossification occurs, with a very thin layer of cartilage present in the condylar head. This remnant persists until second decade of the life and is important for the growth of mandible. Development of the cranial base and jaws. The condylar cartilage develops initially as an independent secondary cartilage which is separated by a considerable gap from the body of the mandible. Early in fetal life, it fuses with the developing mandibular ramus. Separate areas of mesenchymal condensation at the 8th week. Fusion of the cartilage with the mandibular body at 4 months. And at birth, this is the situation. Development of the cranial base and jaws. We are discussing the maxilla forms initially from a center of the mesenchymal condensation in the maxillary process. This area is located on the lateral surface of the nasal capsule, the most anterior part of the chondrocranium. Although the growth of the chondrocranium contributes to lengthening of the head and anterior displacement of the maxilla, it does not contribute directly to the formation of maxillary bone. Maxilla develops from the center of ossification in maxillary process of the first branchial arch. Center of ossification is angle between the divisions where the anterosuperior dental nerve is given off from inferior orbital nerve, from where it spreads posteriorly, anteriorly, and superiorly. No arch cartilage is present, so maxilla develops in close association with the nasal cartilage. One secondary cartilage also contributes to maxillary development, that is zygomatic cartilage, which later is going to be replaced by the bone. In terms of orthodontics, the most important thing is the different growth pattern of the maxilla and mandible during the antenatal life. As a result, the antero-posterior relationship of jaws is changing. The tongue and the mandible of the 6 to 8 weeks old embryo are posteriorly positioned relative to the maxilla. At this time, mandible is too short, and that is going to give the primary embryo-mandibular retrognathism. Within the next month, mandible tends to grow faster as compared to maxilla. This change allows depression of the tongue from the common oral and nasal cavity to the oral cavity. The tongue is losing the contact with the nasal septum, and the oral and nasal cavities can be isolated by the connecting palatal processes. So this is how the tongue, it will be provided the space to go down. If this is not happening, then there will be chances of developing the clefting, because tongue is not going to regress, it is not going to descend at the lower level, and palatal shells are not going to unite. During the last period of the antenatal development, the accelerated growth of cranial cavity and the upper facial skeleton causes the secondary embryo-mandibular retrognatism. This is the secondary embryo-mandibular retrognatism. At the time of birth, the mandible is in its physiological rest position. The relative lack of growth of the lower jaw prenatally also makes birth easier, since a prominent bony chin at the time of birth would be a considerable problem in passage through the birth canal. By the age of 6 months, mandible will have reached the right position relative to the maxilla postnatally. It is probably due to the muscle function during the sucking. At birth, the appearance of the jaw relief reflects their complicated development. The alveolar arches, also called the gum pads, are horseshoe-shaped in the maxilla and U-shaped in the mandible. They are low and the vault of the palate is very shallow. The alveolar part is separated on its palatal side from the hard palate by a continuous horizontal groove, which is known as the dental or gingival groove. In the frontal region, the groove is bridged by incisive papillae, and the gum pad along the anterior part of the palate form the incisal plateau. At birth, the maxillary and mandibular gum pads have 20 segmented elevations corresponding to the unerupted deciduous teeth. The groove that marks the distal margins of the canine segment continues into the buccal sulcus, that is known as the lateral sulcus. At birth, the gum pads rarely come into occlusion. They are separated vertically when at rest. When pressed against each other, they are mostly still separated anteriorly, and the space sometimes extends backwards as far as the canine region. Transversely, the upper alveolar arch is slightly wider than the lower one. If the incisal plateau is horizontal, there is no overlapping of the gum pads, and the lower gum pad occlude with the incisal plateau about 2 to 8 mm posteriorly to its border because of mandibular rest position. The other extreme is the very sheer plateau, which completely overlaps the lower gum pad. It's usually a predecessor for the later development of class 2 div 2, where there will be deep bite, retroclination of the upper incisors because of their sheer position. The majority cases are between these two extremes. So over here, we are done with our today's lecture. And soon, inshallah, we will meet again and we will, like any new topic, if you want some topic specifically to be discussed, I am available to you and we can discuss some topic. I can suggest one thing, if everybody is okay with that, we can go for the etiology of malocclusion, since we are doing growth and development and we have already done the embryology. So if you want, we can also go for the development of malocclusion. Its etiology we can discuss in the next lecture. Let me know and I will be with you next
Thank you,
Monday,
sir.
inshallah.
Thank you. Thank you so much. If
Thank
anybody has any questions, they can just type them down in the comment section. And sir, like you mentioned, we should do the etiology of malnutrition. I think it's very important from dentistry point of view. So we'll definitely, keep a lecture about that as well. So thank you so much, and
Thank
I'm
you
going
very
to.
much. And any questions, any queries on these topics, you can always type it under the comment section where the video is being uploaded, and I will definitely get back to you on that. Okay, thank you very much. Allah
Okay, sir.
Hafiz.
Allah Hafiz. Allah Hafiz.